memorized all my slides, so even if I don't, just kidding. I just want to thank you so much for having me here. I want to thank Professor Drakma Zawari for having me and for sponsoring this, and Professor Shohat for having us and sponsoring this symposium as well. And of course, my colleague, Professor Zisberg. She was actually my very first doctoral student. That tells you how long we've been together. And she actually is, I have to tell you, the most brilliant of all that I've ever met. And you can see the passion that she has and her excitement. And I'm so thrilled to be able to come visit you here in Israel and to see what's going on here and to understand more about what's happening in this country as well. So thank you. I'm going to be talking about healthy aging, living life to the fullest today. And I'm going to talk a little bit about healthy aging at first, and then give you some examples of 2 areas of research that I've been involved with in the last few years that are promoting healthy aging. And then I have some ideas about how we can all work together to create a better world for people who are aging. So that's what I plan to do today. Thank you. I'm starting with letting you know, have you all met Jean-Louise Calment before? Have any of you met her or heard about her? So she's the oldest person ever who lived on this planet. She died at 122 years old and 164 days. And she said on her 120th birthday, "I'm very brave and I'm afraid of nothing. I've only got one wrinkle and I'm sitting on it. And I took pleasure when I could. I acted clearly and morally and without regret. I'm very lucky." In France, she had an apartment there that you had to get in line to get. It was a state-regulated, rent-controlled apartment, and she had one of these. So there were people waiting for her death, hoping to get her beautiful apartment. She outlived about 5 different people who got on the list after they were 80, and she stayed on and on. The reason I bring her up is that for so long, when I started in gerontology, which is in the 80s, the whole view of it was very negative. It was about getting depressed, getting, failure. It was about decline, all those concepts, and a lot about death, mostly about death. And what I really get inspired by is understanding and thinking about what gets someone to an older age. Not that I glorify old age. We all need to live to be 122, because I really don't want to live to be 122. But what is it about her that's different than other people? And I've always been very curious about what does it mean to be able to get old. And there's a really interesting study that's going on around centenarians, people who get to be 100 years old. And it's a longitudinal study in the United States. And there are actually more and more people over 100 all the time. And there's some interesting secrets about them. They tend to have very strong routines and ideas about how they want to live their life. They keep going with their routines. Many of them play a musical instrument. Is that a chance? Is it because music is a way to experience emotion and it's also psychomotor? What is it about music that is such an interesting thing that seems to be associated with living a long time? But they also stay very active in their mind and connected. That's sort of a tendency of people who are older. So there's things to be learned, and we don't have the answers yet. But just as we look at the issues that are the challenges of aging, we also need to be thinking about what keeps people vibrant and engaged and connected, and aging in the best possible way for them, according to their own values and desires and goals with their families. I wanted to just mention the oldest person now who's living, and she's Kane Tanaka in Japan. She's 116 and a half years old. And there are people who are always standing in line. The person who's 116 and a quarter is watching her, hoping that they will get to have the record in the world soon. But this tends to be the kind of the lifespan that seems to be more typical. There have been quite a few people who've reached this age in the last few years. Then I always, I love cats. So I had to talk about Cream Puff, who's the oldest cat ever, 38 years and 3 days. So her owner had her from when she was a very small child until she was quite advanced. And you can see that Cream Puff liked some good things as she got old. She enjoyed turkey bacon and eggs and asparagus and broccoli and coffee with heavy cream. So she was an engaged cat. And then I want to bring up the oldest trees in the world. And these are the Bristlecone Pines. And I've been to this forest where the Bristlecone Pines are. And it is so amazing to look at trees that are over 5,000 years old. And I'm in Israel, where you have so many antiquities and so much that is coming from centuries. And I think this gives you a perspective of the beauty of age. I look at this tree and I think, why do we look at wrinkles and think that they're bad? And you look at this tree and it's been in the wind. It has hardly too much greenery on it because the wind has just beaten it over the decades and centuries. And here is this tree that is just absolutely gorgeous. And we look at it and we say, wow, what a beautiful tree. We need to look at our people and our cats and our goldfish who age and think of all of them in the same way that, what is the beauty of that aging? So I want to talk about the reality of what's happening in the world with aging. And it's not as a, oh, you okay there? It's good she does Zumba. That keeps her. So, so I'm not bringing it up as a tsunami crisis, but I'm bringing it up as a reality of something we all need to think about. I'm so excited to see you all here in this room because you're interested in the topic. That means that we will all be doing something to make the world better for ourselves and for others as we get older. But the numbers are really staggering. I don't need to share it with you. You've seen these numbers. What we're seeing is a real change in the makeup of society. And the trends that are really important is, for the first time in the history of the world, we have more grandparents than we have grandchildren. And in the United States right now, someone turns 70 every 8 seconds. 70 every 8 seconds. And that's going to happen for 30 years. So there's a lot of people coming into this time of life that's older. And people are moving around a lot more than they used to. You get people all over the world. Families are spread. They're not all staying in the same house where they used to be. And there's changes in configurations of families. This is one of my favorite pictures. There's 6 generations here in this picture. Starting with Lily Mae, who's 1 month old, going up to Dorothy, who's 103. And I remember when I'm a geriatric nurse practitioner, and I had a care conference once, and a person came in to talk to me. And she wanted to talk to me about her mother, and her mother was 85. She was 65, and her grandmother came to the meeting as well, who was 105. And they wanted to talk to me about the person who was 85 who has dementia. And the mother, who was 105, had cared for her husband with dementia and was worried about her daughter. So you've got to think about aging. One of the comments that was made by the last speaker is how diverse aging is. We have people who are over 65, 3 generations worth in a family. That's staggering. And so there's people who are working still, people who are doing all sorts of different things, different levels of function within that same age category. And for that person in the middle, for Lucy, who's 57, and for Natalie, who's 37, they're dealing with both the children and their grandchildren they're caring for and thinking about, and also their parents. So it's really a different dynamic. It means we have to think very differently about, parent care leave. We've always thought about parent care, maternity leave. What do we need to do to think about how are we going to care for older adults as well? So the gerontologists are really interested in aging. That's, of course, their topic. And I think one of the most important questions that the field is dealing with is not so much how do you make age longer, how do you keep people alive longer, but how do you make sure that they're living as optimally, as much as they want to in the best way possible for as long as possible. So the dream most people have is, I'm going to live really, 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 really long, and then I'm going to drop dead. In my sleep, preferably, so I don't even know it happened. And it's going to happen at very late life, and that's what everybody dreams about. And that's what you see on that graph there, that the green bar goes all the way over till you drop. And what happens for many people is a decline from a certain age, where they start to have challenges with function, whether it's cognitive or physical, and they start to have difficulties. And so what we can all work on and really commit to for ourselves and in our practices is trying to push that curve up to optimize how long people can be healthy, how long people can be vital. So paying attention to things like nutrition and physical activity and sleep, those kinds of issues, and the strategies we use to try to promote those issues in people are all strategies that help push that curve. So the work that I do in my interests really relate to pushing that curve and optimizing how people can age. Chronic disease is something that's a reality. For the first time a couple of years ago, it exceeded communicable disease as the leading cause of death in the world. So chronic disease is something that affects many people as they get older, and often more than one chronic disease. And it's usually something that is associated with some kind of functional complication. So the more we can do to actually prevent the onset of chronic disease and manage chronic disease as we get older, the more we'll be able to contribute to pushing that curve. And there are 4 common causes with chronic diseases. They're common across things like diabetes, hypertension, heart disease, and they have to do with diet, with physical activity, with your medications, with alcohol consumption. So those are the kinds of things we can strategize on. Yes? And sleep. Thank you very much. And sleep. We'll add sleep to the list. You're right. So that's an area that I think we should have in our mind as we're thinking about care, about interventions. It's about that prevention and the promotion of health. There's some healthcare trends that are also important as we think about this issue of what are we all going to do. And those have to do with what's going on in our healthcare system. You've heard probably of sicker and quicker discharging. People get out of the hospital faster than they ever did before, and they need a lot more help once they get home. And at the same time, the kinds of services in our communities are also expanding, and they have more choice, but it's sometimes difficult to navigate that and difficult for families to understand. And people more and more want to be at home as much as possible, and they also want to be more and more in control of their own health and care. That means that we, as healthcare providers, need to change our attitude and our approach to working with older adults. So I'm going to talk about 2 studies briefly to give you a sense of what I've been working on. The first is a program on improving health and diabetes. And it was a randomized clinical trial. And I believe you start aging when you're born or even before that. And so that if you want to be a healthy older person, you've got to be healthy throughout your life. And so diabetes is one of the single biggest causes of disability and one of the most common chronic conditions that for type 2 diabetes is highly preventable and manageable. So I wanted to work on an issue that would help people to age longer and better. The other reason I think that diabetes, I'm not a diabetes expert, but the reason I wanted to look at diabetes was I think it entails many of the elements of lifestyle and behavioral health that are important for other chronic conditions. So we embarked on this clinical trial, and it's intriguing to me because it's similar to other chronic diseases in that people live with this disease constantly, and they have to make decisions day to day in many small ways. You know, what am I going to do with my activity? How am I going to eat? What should I eat? What do I do in the social situation? Lots of different questions come up on a daily basis. And so it was something that we felt was important from being very tailored to the individual and thinking about how technology could actually help this problem. So we started by going and talking to people who have diabetes and asking them about what it's like to live with diabetes. And with that, we came up with 4 major themes. First is that it's pervasive. It's there all the time. It's something they're thinking about all the time. The second is that they have to worry about surveillance, tracking their blood glucose. They've got to track their activity. Third is that they feel very lonely. Even if there are people who care about them, no one else is going through what they're going through. And then finally, that it's hard to stay in control and find motivation. How many of you have ever been on a diet? I mean, how hard is it to stay on a diet or something that's a restrictive regimen? We also looked at what is it about the disease that might have an impact on an intervention. So, you know, how long have they had it? How well in control are they? Those kinds of variables. And then we designed our intervention to address these concerns. And our intervention includes 3 main things. It includes giving them data, the ability to track their own data using an activity tracker, having a coach, a nurse who works with them in interpreting the data, and thirdly, integrating the data into the electronic health record so that when they go to see a clinician, not only is their med on the list and their lab work, but their own contribution to their health is visualized in the EHR so people can see it and can reward them and recognize what they've been doing. So we wanted to make sure that we could help people look at data that they generate about themselves in the form of activity or other kinds of data and help them get meaning out of that data. So the coach would sit with someone and look at the data and say, oh, look, let's see. You're having trouble with your activity on some days. What's going on those days? And using motivational interviewing, which is a technique to elicit their engagement, we had them explore what they could do to improve those kinds of issues. We also helped them notice their own patterns. So we noticed, for example, activity relates to sleep. So what does that mean for you? And what can that mean in terms of when you're active and how well you sleep? What about your nighttime meals? What about, so looking at the data, we were able to help them customize their approach for themselves. So it was an intervention that actually lasted 3 months, and we oriented people, we randomized people to getting this intervention, or to just be oriented to the hospital electronic health record, where there's a patient portal, where there's some education that they can look at. So they were compared. And we had people who didn't have technology. Many of them, about 70%, didn't have a cell phone, which is not typical for Israel. I know you have a lot more mobile phones here. But so we gave them the technology, and we wanted to prove that people who are older actually can learn new tricks and that they can adopt technology. And it turns out that people actually were very interested and engaged with the technology. And then we worked with them with 6 sessions that were telephonic, where the nurse talked with them over the phone and coached them in their goals. And then we followed them for 6 months after that. And what we found is that the majority of people actually chose an activity goal. They could choose whatever goal they wanted, but activity was the most common, followed by nutrition. And actually being able to monitor their activity, they were able to change their steps per week from around 11 kilometers to 32 kilometers in 3 months. And 6 months later, but when we hadn't even talked to them for 6 months at all, they were still at 26 kilometers a week. For this group, who was very sedentary, that was a real improvement. We also were able to see that it changed their feeling of empowerment about their condition, that they were able to actually think of how they could make an effect, have a change in their life. It also affected their depressive symptoms, and then it also improved their stress, but not significantly. The reason I think some of this didn't end up being significant was that the usual care group also improved because they had access to education, but the intervention group improved substantially. At the end, we also went to did focus groups and asked them, now what's it like living with diabetes? And you remember we talked earlier about pervasiveness and vigilance and the isolation and the control issues. At the end of the study, they changed their conversation. They were talking differently about their disease. They were talking about it as having a perspective on what it meant to live with the condition. They were aware rather than vigilant. Vigilant implies you're afraid. You're scared something's going to go wrong. But here they were more aware of what it means to them. They felt they had support, and they felt they had more ownership rather than control. So in our minds, we felt that this intervention helped them to shift their way of thinking about their condition. And we hope that it helps them to manage other conditions and that it might be applicable to others. So now I'm going to switch gears and talk about family caregiving briefly. Rosalind Carter, who's one of our former presidents, said that there are actually 4 presidents' wives, 4 kinds of people in the world. Those who have been caregivers, raise your hand if you've been a caregiver. Those who are currently a caregiver, raise your hand. Okay. And these are the 5 people I worry about every single day, these that I'm caring for. And then we've got people who will be caregivers. How many of you think you'll ever have to do this? And then there are people who will need caregivers. Anyone in the room think you're going to need someone? Okay. And that's me on the right with a walker and a cast because I broke my leg and I was stunned by how much care I needed. And so it's something that becomes very real very quickly. And many of our caregivers are invisible in the community, in our families, and in the healthcare system. So I want to talk to you about family caregiving. And you probably are familiar with this, that family caregivers do an awful lot of support for older adults. Much of it's invisible. They support people in their daily lives. They actually help with self-care. They do emotional support, a lot of financial and legal support, advocacy, and surrogacy. These are the general kinds of things caregivers do. We just completed a national study in the United States of caregivers, and it's called the Home Alone Study, and you can look it up on this website here. And what we did was survey, it was a national probabilistic sample, so it was a representative sample. And we surveyed people to ask them about, are you caring? And we found over 2,000 people in the study who are caregivers. And then this is the survey of what they told us. First of all, that they're providing intensive care, actually. It's not just about helping people go to the bathroom or buying food for them. 50% are helping with what we consider medical nursing tasks. So medications, wound care, a variety of different tasks, which is very high. We also found that they're diverse, and so are their experiences, that they actually range in age from millennials all the way up to people who are older. That those who are socially isolated and have no choice are actually more at risk for having problems and psychological effects from their care. That those who are performing more care and more tasks receive both more positive and more negative effects. So it actually is, there's rewards to it as well as demands. And then finally, that they're mainly very much on their own. That while the health systems think, oh yes, we do discharge planning, and oh yes, we instruct people when they leave, the caregivers tell us they don't actually feel that they got adequate instruction. They don't actually feel prepared. And when they get home and they're dealing with something that's scary to them, they suddenly find themselves quite at sea. As a new nurse, I was terrified to give an injection the first time. I don't know if any of you felt that way, but I was terrified. Can you imagine if it's your mom, someone you love, and you've never done it before, and now you're at home? So for people having to do these things for the first time, it's very frightening. This is just a count of the kinds of care that people are giving, and you can see from this that medications is really common, 80%, but there's some other interesting ones as well. Helping with mobility, special diets, wound care, meters and monitors, incontinence, a variety of different topics. So there's a lot going on in this type of care. And that importantly, people mostly learn on their own. And the things that they learn on their own the most are about incontinence and special diets and bowel care. And these are things that you can think about it. You know, you have surgery, there's a wound, it's obvious. Go ahead and teach them how to change a dressing. But something like incontinence sometimes comes on suddenly, and families may not know that it should be assessed. It should be looked at. It may be preventable. It may be something that can be managed. Special diets we take for granted. We all cook. We have to cook our meals. But for families who are asked to do something different with texture or with different types of formulations for the person, it's very challenging. And we really leave them out of helping them to understand this. This is a really important finding, I think, for us in our practices. And men are less likely to get instruction than women. And millennials, younger people who are caring and are the primary caregiver, are less likely to get instruction. I want to talk about social isolation, because isolation is something that we know affects health. If you're connected to people, if you have social connections, you have lower mortality. It's an important piece of life. And family caregivers tend to become more isolated when they're involved in intense care at home. So it's something for us to pay attention to. And those who are more isolated are those who are experiencing more stress. They feel that they have to constantly watch what's going on. They feel they have no choice. And they perceive and they worry. They perceive things as being very difficult. So those are the ones you really want to pay attention to in supporting. It's interesting to note that many people don't feel they have a choice in family caregiving, that in fact the majority don't have a choice. It's just something that's assumed they're going to be doing it. And that when you don't have a choice, it actually has an effect on how you perceive the situation. And we as healthcare professionals often assume that people are ready, able, and willing to care. And sometimes there'll be a family where the child was abused by the parents, and now they have to turn around and provide care. And they're very complicated issues in those kinds of situations that are worth our assessment and understanding. I want to talk now a little bit in my last few minutes with you about solutions and things that we can be thinking about. And it's an array of different ideas, and I hope that some of them resonate with you depending on where you are and what you're doing. I think technology holds a lot of promise in many ways for older adults in enhancing their lives, improving care, and enabling people to be more independent longer, live in their homes for longer. Some of these technologies are things that you wear on your body, so activity trackers or devices that actually can convey information to other people. Some of these devices are in your home. Some of them could be passive, things that, for example, will signal and remind someone they haven't opened the fridge yet and had their breakfast or turned their kettle on. Maybe you should turn it on and have some breakfast. Or reminders that if you haven't got out of bed, send a signal to you. Maybe it's time to get up and out of bed if it's your routine is to be up already. And if you don't get up, then signal someone else to check up on you. So there's passive kinds of monitors that are possible. There are also monitors that actual controls and sensors that control the home environment. So controlling temperature, controlling security. But for people with cognitive impairment, for example, there's places that are starting to have sprinklers outside. So if someone starts to leave the house when they shouldn't, the sprinklers come on. And that sort of gets them to not leave the house at that moment and prefer not to get wet. And it's a very, very low-tech way to be able to help control help with wandering behaviors. And there's also things that are going on in terms of communication. So our communication using apps, using SMS messaging, using websites. There's a lot of peer support available to people on the web. So all of these things are possible. And I think that our challenge for older adults is, first of all, making sure that these technologies are user-friendly, that there's actually an ability for people to engage with the technology. And secondly, looking at ways to integrate all the information that comes in with technology and is being used into a way that is actually actionable for us. So turning information into wisdom that's actionable so that we can use it to improve care and for them to have the feedback that they need about their lives. The second area is around community solutions. And there are a number of different things with community. First of all, I think, and some of you who are in public health or community health nursing will resonate with this, the idea that we have to be thinking of our communities as a whole for what is the delivery system looking like for older adults? How responsive is it to older adults? How much is it able to be accessible and useful and tailored? Most of our health systems were developed at a time where older adults were a small portion of the care. Hospitals, for example, the design, the lighting at night, the noise. There's so many aspects of hospitals that are just really bad for old people. And they were designed, they're probably not good for any people, but really bad for old people. And so, we need to think about our design in our communities that would help with that. Supports for people who are family caregiving and distance caregiving. Health promotion and respite. I was interested last night, Anna and I were walking back from our Zumba class, and we went by a playground, and there was a children's playground, and in the middle was an outdoor area for doing exercise for adults. What a wonderful way to combine outdoor activity and socialization. That's a community planning issue, and having sidewalks that are walkable, those kinds of things that are important for older adults. Ways to bring people together and address isolation. Isolation is such a difficult problem for people. And, the more we can find ways to connect meaningfully and think about the ways that people can be engaged in reciprocity, giving back to each other and having a meaningful role within our networks. And then looking at systems of care. The community-based services are often not connected too well to the healthcare systems. And yet transportation, nutrition, and those kinds of things are vital for health. And we need to do better at talking between our systems. And then finally, emergency preparedness, so that we know in our neighborhoods people who might be at risk, who might need extra assistance and support during emergencies. For healthcare professionals, I'm thrilled to see you all here in this room committed to this area of interest. We're really in a minority in our healthcare. I was told as a young nurse, don't go into gerontology, you're way too smart for that. And that was by a very good faculty member who was a professor of mine. And I think that we haven't had enough people come into our field with the knowledge and expertise you have. It's something we've got to keep working. So once you are in this field, you have a job to be an ambassador and bring other people into the field as well. We also need to look at how we work better with family caregivers. They are the experts on care for the person they're living with and that they care for. And we often think, oh, now I'm the expert. I'm here. I'll take over and tell you what to do. But it's really about that partnership that's so vital. Full practice authority. And this is an issue in the States, and I think it's an issue globally about who is doing what in our healthcare system and how can we make our roles the best they possibly can be to contribute to the health and well-being of the populations we serve. So in many ways, nurses are underused and used for the wrong things that other people could do, and our expertise could be applied in different ways. And there's a whole body of work on how to optimize the very precious resource we have of physicians, of nurses, physical therapists, social workers, psychologists, everyone. We all are in short supply, but we need to be more open-minded about how we design our care to be able to deliver care effectively. Working together as interprofessionals is vital. The problems we have with older adults are much more complex for one profession to solve. And we all have our disciplinary traditions of what we do in our practice, which is very, very important. And we need to communicate with each other about what it is we do and the roles that we play, and do that in an effective way so we can all advance health for the older adults. And then the innovation part. We spend a lot of time in healthcare trying to do quality control and standards where it makes everything the same, and it kind of makes things, in some ways, we tend to make things too standard at the expense of innovation and creativity. And I think we need to have a balance between the standards and the tailoring, the innovation that needs to be there to really develop and deliver person-centered care. And then diversity in our workforce. This is certainly an issue for us. It's an issue globally of having enough people in our profession who represent the people we serve, and that people are aware and understanding of the diversity of the people we're caring for. Because it's not just their race, ethnicity, and religion, but there's so many other dimensions of diversity that are important for us to understand and value. And then finally, healthcare systems to promote healthy aging. I'm a big believer that the only reason we exist as healthcare professionals is our social contract. We're there to improve health. Fundamentally, that's what we're there to do. And it should be centered on the person and the family and their goals and their values. And our health system needs to be aligned that way. Many of our systems have been created to be provider-centric, at my convenience. They're not at the convenience of the person we're caring for. The second is the idea of trajectory, that we may see people in a hospital or we may see them in a clinic. That's one tiny moment in their life. They're living their lives the whole rest of the time without the white coats, and they're doing just fine, thank you very much. And what we need to be thinking about much more is that trajectory of a person, where they are on their trajectory, what's happening for them, and how much can we anticipate and imagine might be next to help guide them and provide supports that are proactive so they don't have the crisis. So if someone's vulnerable already, how do we help them predict when they might be at risk for having to go to the hospital again? And what could they do to prevent having to go? So it's that trajectory perspective that I think is vital. The idea of care everywhere, that doesn't have to happen where the white coats are. You know, our schools, our libraries, our parks, all of those places are places to promote health. And having a much better connection between public health and public good, it will really promote health much more. The whole person, looking at their goals, their values, not just their list of diseases, their list of medications. That's just such a tiny piece of who they are, and understanding the whole person in care, including the family caregivers. And even if there's not family caregivers, and when I say family, I don't mean necessarily blood. They are people that someone considers their family. It's someone they consider someone important in their life, caring for them. To the extent that people want it, promoting self-management, helping people to understand their condition and what they can do, and help them to figure out what makes sense for them. The connection in the community and the connection within the health systems. And then finally, of course, cultural diversity and health equity are vital issues for us. In our systems, which are really designed to not be equitable in many respects. So these are the thoughts that I have. I've just been such an honor to be here with you today. I look forward to talking with some of you on breaks, and thank you again so very much for having me here.